everybody, welcome to this video on how to code for your clinic visits. So really when it comes to coding, there's two options. Okay, there's coding for time and there's medical decision making as far as I'm concerned. And I think that's really about it. But those are the two that I focus on. So when it comes to time-based coding, this is really simple, right? You spend X amount of time prepping for, seeing, documenting, reviewing, communicating, all that kind of stuff about that patient case, okay? That's pretty simple. If you have a 20-minute visit, you spend 20 minutes doing all that stuff. You spend 30 minutes doing all that stuff. You put a little blurb about how you spent 25, 35, 40 minutes, whatever it is, engaged in that patient encounter. And that's how you can bill for it, plain and simple. It's a very straightforward, simple way to do it. The trouble with doing that is if you have 15 to 20 minute appointments all day, but you're saying you're spending 40 minutes with every single patient, you can see the problem with that, right? Over time, you're going to have to prove that you spend all that extra time prepping and documenting for that patient, okay? So that's something that can easily be audited. And if you're saying you're spending 40 plus minutes with every patient, but in reality, you're only spending 20 minutes with every patient, then that can be a huge problem, right? So you audit that, then you can be held responsible for that dishonesty, I guess is what it could be. If you say you're spending 40 minutes, unless you really are, right? If you're spending a couple hours before clinic and a couple hours after clinic, then by all means put 40 minutes and say that you're doing that. But don't put 40 minutes if you're not spending 40 minutes, essentially, okay? Basically, there's only so much time in a day, and that's a simple way that people can look at that and say, are you really spending 40 or 50 minutes with every single patient? You got to be honest there, okay? With medical decision making, it's all about complexity. Okay, so complexity is determined by how many chronic or acute issues you're dealing with. Is there an exacerbation? How stable are they? Are you reviewing outside tests, new tests, or doing prescription drug management? Billing for this one is simple too. It's based on your documentation. Okay, so if you can see a level 4 in 5 minutes as it's routine stuff with no exacerbation, then you just have to document it and prove it's a level 4 through your documentation, and that's something that I will show you. That's the nice part about this, is you just have to make sure the documentation is up to snuff, right? You don't have to say that you spent 40 minutes, you just have to document appropriately. So both are ways to bill. I prefer medical decision making because then I don't have to justify my time. I can just base it on my documentation, which is simple, super easy. If you have templates, you can get a level 4 visit done in 5 minutes, super easy, right? When I see a level 5 visit, if I spend more than 40 minutes with an established patient, then I make it a level 5 visit and then I bill as such. But I make sure that my timing is built that way. So timing is pretty simple. I'll talk about billing based on time in future lectures. Medical decision making takes a little bit more finesse. Okay, it takes a little bit more looking at this and kind of going over it a few times. So when it comes to medical decision making, there are 3 columns or 3 categories that you have to meet 2 of the 3 in order to bill a certain level. Okay, so you look at level, let me move my head out of the way here. Look at a level 4, okay, a moderate bill. So for level 4, if you want to bill based on 2 of the 3 categories, I usually say the easiest one to do is the number and complexity of problems, because if you have 2 or more stable chronic illnesses, when it comes to your documentation, the patient visit, you meet this category easy, okay? Or you have 1 acute illness with systemic symptoms, 1 undiagnosed new problem with uncertain prognosis, but 2 or more stable chronic illnesses is really easy to meet. Let me move my head back over here. Now, if you're on a level 4 and you want to get your second column, then an example of management would be something like prescription drug management. Okay, when it comes over here, risk of complication and morbidity, mortality from patient management. If you are managing prescriptions, and that can be as simple as continue current amlodipine, continue current lisinopril, then that can be checked off in this category, right? So just based on, hey, you have high blood pressure, you have high cholesterol, and we're continuing your statin, we're continuing your ACE or ARB, then you meet 2 of those 3 categories, right? So now you can build out a level 4 easy. Okay, if you look at any tests, you review any tests, anything like that, that can get this other category, but you only have to have 2 of these 3 categories, okay? That's how this works. You only have to have 2 of the 3 categories to meet this, okay? So that's why level 5 is tough, because 1 or more chronic illness with severe exacerbation, or 1 acute illness that poses a threat to life or bodily function, drug therapy requiring intensive monitoring for toxicity, right? These types of things are not happening in the clinic too often. So I don't ever bill level 5 based on medical decision making. I only bill level 5 based on time. That's the only way that I feel like I can personally justify it. So, and then level 3, one stable chronic illness, one acute uncomplicated illness or injury, reviewing external tests, ordering each unique test, review of each unique test. Basically, with this one, I say if they have one acute illness, like a viral URI, where you're prescribing something for the cough and you're ordering a strep test and you're looking at previous notes, or you're reviewing, previous lab tests or something like that to make sure they don't have kidney dysfunction before you prescribe something, that qualifies as this. But really, level 3 can be very low risk of morbidity and mortality from additional testing, right? You can easily meet this one and this one. If you're doing any kind of prescription drug management, if you're doing any kind of ordering of tests, you can easily meet a level 3 for a viral URI or a pharyngitis visit. Or if a patient comes in and they just have high blood pressure and they're just there for that, then you can easily review that real quick and see if it's a level 3. One trick that I like to do, and we'll talk about this a little more, is if somebody's just there for hypertension, I look at their labs and I say, okay, have they ever been pre-diabetic? Have they ever had high cholesterol? Do they have vitamin D deficiency? Do they have anything else that I could tack onto that to make it a level 4, and that we could talk about it? Great, because not only is it good care, if they have high cholesterol, then we need to talk about that. We need to see how it's looking, right? We need to pay attention to it. It's not manipulating the documentation to get a higher code. It's good care, but it also is getting a higher code, because then at the end of the day, that visit becomes, worth 0.6 more RVUs. And I'm going to do those things anyways. I'm going to look at the cholesterol. I'm going to look at their past labs to see if there's anything there that we need to talk about before I just code the visit for hypertension. So if you're doing the work, if you are looking at the labs, previous labs, if you're looking for, high cholesterol, prediabetes, their high blood pressure, all that kind of stuff, any other diagnoses or problems that have existed, and you find one, then document it and get paid for it. Plain and simple. Don't look for it and then not document it and don't get paid for it, right? If you're going to look for it, manage it, treat it, then get paid for it. So that's why I say the majority of family medicine visits and visits in the clinic in general should be level 4 visits. There should hardly ever be a level 3 visit unless they're coming in for an acute, hey, I have a cough, cold, that kind of stuff. Boom, it's easily a level 3. But if they have a cough, cold, and they ask you about their high blood pressure medicine, they ask you about their cholesterol medicine, then that's a level 4, right? If they ask you about those things, or you review it in the tests and you mention it and you say, hey, you had high cholesterol 2 years ago, we should recheck that. Are you on a statin? And they say, oh, yes, I'm on a statin. I forgot to tell the nurse that. Then great, boom. 2 stable chronic illnesses. That's a level 4 visit. Essentially, what I want to tell you is get paid for what you're doing. So many doctors and so many other providers will say, oh, well, the patient's just here for high blood pressure. And then the patient will ask them about their high cholesterol. They'll ask them about their thyroid. They'll ask them about all kinds of things, but they won't bill a level 4 because they feel like that visit was easy. It doesn't matter how easy it was for you. It matters if it meets the criteria. So if it meets the criteria, bill it a level 4, get the RVUs that you deserve for that visit, and plain and simple, bill it based on MDM, okay, medical decision making. If you do it based on medical decision making, you can always justify it. It will always stand up in audits because your documentation represents that. So I never advocate to lie on a chart or anything like that. Okay, don't do that. But if you talk about it, even if it's, hey, how's that blood pressure medicine doing? I noticed your blood pressure looks good today. And they say, oh, it's just fine. Great, you talked about it. You addressed it. Boom, put it in the note. That becomes another chronic problem that can go to build your list to make it a level 4 visit. Okay. That is the goal, to get it to a level 4 visit. But if they strictly don't have any problems, don't manipulate the chart to make it that way. Okay, plain and simple. If they have 2+ stable chronic illnesses, talk to them about it. So anyways, I'll quit beating that dead horse. This medical decision making can be a little complicated. That's why I wanted to pull the chart up here. We'll talk about it again as we go, but essentially no, level 3, 4, those are the 2 things that you should be billing based on medical decision making. Okay, we'll get into it again with more about lectures and whatnot, but anyways, just wanted to introduce it to you. We'll see you in the next video.